into clouds. Oh no, that's the recording. No, I don't want to do that. So I want to. No, it's still recording. Oh gosh.
I will pause.
Very kind. For a very kind introduction. I just thought I'd put my declarations up, but please understand that tonight I'm presenting my own work and my own insights from the knowledge that I've tried to gain over the last 24 years in the program. So this is hopefully the learning outcomes that we'll achieve. We'll just have a bit of a quick update on why it's so important to plan a catch-up schedule and certainly identify those individuals that are overdue for vaccinations. We're going to plan some catch-ups. We'll look at some overseas immunisation records as well. But I suppose, you know, looking right at the bottom basics of it all, there is a national immunisation schedule, but each state and territory have a version of their own. And because the states and territories themselves will quite often run state-funded immunisation programs, and we've certainly got those in place here in South Australia, such as a meningococcal B program for all infants. So, like I said, there are some differences in the schedule, but you know, for us here in South Australia, obviously, like I said, we've got our state-funded Bexsero program, and we are one of the regions that offers additional pneumococcal vaccines to Aboriginal and Torres Strait Islander children as well. And so for these individuals, you know, those little babies, that additional dose of Prevnar 13 is recommended, and it's funded under the NIP for those bubs at 6 months of age. And of course, they would follow on and have Pneumovax 23, also funded under the NIP when they're 4 years of age, and a second dose, of course, 5 years later. We know that our Bexsero vaccine can be safely administered with all of the other NIP vaccines, and we can certainly do multiple injections, as you are well aware, as long as there's that separation of injection sites by 2.5 centimetres. Obviously, all scheduled vaccines should be administered at one visit if possible. And if that's not possible for whatever reason, then definitely the recommendation is to prioritise the administration of vaccines that are on the NIP. So if all, yes?
Sorry, there's a question in Q&A.
Okay. Let me have a little look in the Q&A here. Q&A. Will the South Australia schedule be updated to list men quad-free rather than Nimenrix for adolescents? Yes, it certainly would be. My understanding is that that will happen in due course when the men quad-free program commences. There would be a new schedule coming out, I would imagine, from SA Health.
Thank you.
Okay. So definitely, if all scheduled NIP vaccines cannot be given in one visit, then definitely prioritise the antigens that haven't previously been given. For example, MMR at 12 months of age at that scheduling point. Remember, of course, we're giving that prophylactic use of paracetamol with our Bexsero doses for children that are under 2 years of age. And obviously, parents need to really be schooled up on how to confidently assess for fever, as well as manage fever post-vaccination, and definitely be providers should really be providing some information to parents around that, and certainly who they need to contact or when should they be seeking that additional medical support. So Monica did mention that our session tonight is interactive. So we're going to do a poll to just get you thinking a little bit. And this is around the eligibility for NIP-funded catch-up vaccines. So are NIP catch-up vaccines funded for all children if they are born in Australia, or all children regardless where they were born? Or is it all Medicare eligible individuals? Or is it D, Medicare eligible individuals up to their 20th birthday? With the exception, of course, of HPV, which goes up to their 26th birthday, as well as to refugees and those people that are in our country with a humanitarian visa. So we'll just give you a little bit of time here. You're almost all done. A little bit of chopping and changing around. Okay, I think we're pretty much done it. Okay. All right. So the actual answer, actually, this is the wrong poll here.
Is it?
Yeah, this is the wrong poll. So the first poll was about the eligibility of NIP-funded vaccines.
All right.
So do you have another?
I do have that poll as well. So let's.
Yeah, so we'll just pop that one up perhaps, I think, if we can, Monica. Is that okay?
Sorry, what is it?
It's titled, Who is eligible to receive NIP-funded catch-up vaccines?
Yeah. Is this the right one?
Yes, this is the right one that we're after. Thank you, Monica.
Sorry,
Okay, so we're going to get you to redo your poll. So let's do this poll here. So it's around the eligibility to receive NIP-funded catch-up vaccines. So you should all get that reasonably right, I think. Okay, I think we're pretty much there. A little bit of chopping and changing. Okay, so the answer is actually D. So that all of the vaccines listed on the NIP schedule are free. However, eligibility for free vaccines under the NIP is actually linked to eligibility for Medicare benefits. And so Medicare eligible individuals up to their 20th birthday, with the exception of HPV vaccine, which is up to 26 years of age. Also, refugees and humanitarian visa entrants are eligible for those NIP catch-up vaccines. So for the eligibility for Medicare benefits, that means that they must be an Australian citizen, a New Zealand citizen, an Australian permanent resident, somebody that is applying for permanent residency, or they are here as a temporary resident covered by a ministerial order. Citizens or permanent residents of some other countries, such as the Norfolk Islands, the Cocos or Keeling Islands, Christmas Island and Lord Howe Island also. Others may be able to enrol if they are visiting our country and they are from a country where we have a reciprocal healthcare agreement. And these countries include Belgium, Finland, Italy, Malta, the Netherlands, New Zealand, Norway, Ireland, Slovenia, Sweden, and the United Kingdom. Anybody that is not eligible to hold a Medicare card should be given a private prescription for any vaccines that they require, whether they're catch-up vaccines or primary course vaccines. A lot of people that are in this country that are not eligible for Medicare may well have come from their home country with some type of private health insurance. And so therefore they may be able to claim a rebate back from their own private health insurance company. So you did reasonably well there to get that one right. Perfect. So we certainly know that children can become overdue for vaccination for a multitude of reasons, and I think we've probably heard them all. We've heard every reason under the sun. But the World Health Organization flagged that vaccine hesitancy is one of the top 10 threats to global health, and they made that claim in 2019, just prior to the pandemic. But we also know that since the pandemic, there's been a little bit of a spillover of vaccine hesitancy due to the COVID program. We find that some people have lost confidence in vaccines. They just don't think that they work because they were vaccinated against COVID, and yet they still went ahead and they had lots of episodes of COVID. There's a lot of mistrust from governments because there was constant changing in recommendations during COVID as new information came to light. And we can understand that as health professionals. We understand that as soon as new information comes in, Australia was trying to be as responsive as possible, but unfortunately that has led to mistrust. A lot of parents still think that there's too many vaccines and they overwhelm the immune system. Or maybe some people have had a really negative experience with a vaccine. They've either had a major adverse event of some description, or there's some historical story in the family that, you shouldn't get this tetanus vaccine because great grandma had an allergic reaction to it, those sorts of things. But there's certainly a lot of literature that really demonstrates that many parents admit to having concerns or questions around childhood vaccinations. And for this reason, it's just so important that healthcare providers really understand their reasons for hesitancy, and therefore you're better equipped, I suppose, really to have some time and educate these parents. Certainly education is a key player in equipping parents with that necessary information so they can make that really responsible immunisation decision for their children. There are a minority of people who refuse vaccines. They are the absolute resistors, and they may be conspiracy theorists, people who choose an alternative lifestyle, and that lifestyle actually excludes the use of any conventional medicines. They wouldn't worry about taking antibiotics, or they wouldn't worry about taking paracetamol for pain relief or anything like that. We certainly know that there's some apathy, that they do actually believe in vaccination, but because we have so little vaccine preventable diseases circulating, they just might not think it's that important at this particular time to vaccinate their child. And often this is really just a lack of awareness about vaccine preventable disease. It could be poor health literacy, or they just haven't got around to getting it done. And we certainly know there's a bit of generational amnesia, I suppose, where people have really forgotten how serious these diseases are, and they're kind of a little bit more focused on, it doesn't really matter, these diseases probably aren't that serious, or there's none of them around. We certainly know that life is really busy. It's busier for some than others, but it's busy just the same. But finding time to take off work, to take a child in for vaccination is actually not that easy for some people, and especially if there are no clinics that are offering extended hours, close by to where they live. If the clinics are only open from Monday to Friday, 9 to 5, and they're the hours that parents are working, it's really very, very difficult to get your children vaccinated. We certainly know that there's a lot of disadvantaged people in our community, and those people are disadvantaged in multiple ways. It could be that they have financial disadvantage and they just can't afford to take any time off of work, because if they just don't go to work, they're casual employees. If they don't work, then there is no pay. Or they just can't afford to go to the GP and have to pay a gap with more and more general practices that aren't bulk billing, anymore. So we just need to be really aware of that. Of course, they might be non-Medicare eligible individuals too, and therefore they're going to be paying full cost for the vaccines and for the consult. Maybe they've just got other pressing priorities. We're really hearing about the cost of living pressures at the moment. So those priorities of paying rent, buying food, having heating on these cold winter nights is going to take a higher priority than vaccinating their children. It really could be disadvantaged due to physical or psychological illness as well. And it's just impossible for some people to get to a clinic. And there's not many providers out there that would offer a home vaccination service to these individuals. If you can think of, some of the clients that perhaps that you have coming to your practice, is it a single mum? Maybe she's got depression and anxiety. Maybe she's got 3 children. Maybe she's not working. She doesn't own a car. It means taking 3 children on 2 buses to get to a clinic. And some days with her depression and anxiety, she just can't even get out of bed, never alone organise 3 people to come into your clinic and get vaccinated. So while a lot of people go, vaccination is safe and easy, yes, we know that it's safe, but sometimes it's just not that easy. Of course, there's the whoops, I forgot all about it. And this is probably the most common confession that we hear from parents. They just simply forget, and they just keep forgetting. So one week, just leads to the next, and before long, a whole month or 2 or 3 has slipped by. What we do know is that if you are seeing these parents, please remind them. Please think about the children that they have at home and just do a double check whether, little Johnny and little Sally at home are actually fully vaccinated, or just remind the parents to double check. So the other 2 reasons probably that we do know why children get behind with vaccinations is that the child has been sick. It picks up every virus that's going around. It's on antibiotics, all of those types of excuses. And the other one is the healthcare professional, and that's us. And unfortunately, research does show that healthcare professionals, quite often do not open up the big vaccination conversations. And yet we do know that healthcare professionals are one of the most trusted sources of vaccine information, and a recommendation from a healthcare professional definitely increases vaccine uptake. So we do know that if the healthcare professional doesn't raise it as part of that consult or in a conversation, then it does lead to a missed opportunity. And we've discussed all of those other reasons where we have found that do lead to under-immunisation of children. But the most important preventable single reason is missed opportunity. So the World Health Organization Essential Program on Immunisation defines a missed opportunity to immunise as any contact with a health service that did not result in an eligible child or individual receiving the needed vaccine. But I get it. You are exceptionally time poor. And there is absolutely no magical solution on how to fix that that I can offer you. But there are a few practical solutions, and nurses are one of them. You have many, many, many touch points with patients for a variety of reasons, and vaccine recommendations can come from nurses. We are the seed planters. So as long as we have an opportunity in a conversation to weave in something about a vaccine that might be recommended for them, it just might make the person have a little bit of a think about it. We can often then also help the patient make a future appointment to come back and discuss vaccinations, purely just an appointment for that. And we can certainly help them make that appointment before they leave the clinic. Certainly, another practical solution is to make sure that you do click the View AIR button on your practice management software system for every single client at every single visit. Check if there are any overdue vaccines. Maybe you can vaccinate them today, maybe you can't. But at least the parent is aware and could make another appointment before they leave. Another is to ensure that you have always asked, do you identify your child as Aboriginal or Torres Strait Islander? And just remember that whenever you do ask that question, always follow it up with the reason why you're asking it. And just such as, because if you do, we can offer your child additional vaccines to give your baby more protection from certain diseases. And this will really help ensure that those babies do not miss vaccines that they're scheduled for. And another, of course, is to download that AIR 010A report, or we call it the 10A report from the AIR, to identify patients that are in your practice that are overdue for vaccination, and then, of course, send them out their reminders. Obviously, the golden rules, there's plenty of them, but definitely try and keep children on schedule. And I think really this needs to happen as early as antenatal education. I'm not sure anymore how many people go to antenatal education sessions anymore. I did that many years ago in my career when I was a midwife, but really now with so much online availability for education, etc. And what's on Facebook, of course, which is very important, or TikTok, of course. But maybe they're learning from other sources and not actually going to antenatal education classes. But we really do need to start these conversations very, very early. So if you are seeing women throughout their pregnancy, please start planting seeds around the childhood immunisation program. And really, this is just to help them understand that the program is really important, that staying on schedule is really important, and that these babies need to stay on schedule and receive those vaccines to protect them from those vaccine preventable diseases. Because we know that for as long as that child has not received vaccines, the window of opportunity for that child to contract a vaccine preventable disease, that window is wide open. So we need to really narrow that window as much as possible to reduce that opportunity for disease. Obviously, if they do become overdue for vaccination, just keep calm the farm and catch them up, really. So catch-up vaccination refers to the action of vaccinating an individual who, for whatever reason, is missing or has not received doses of vaccine for which they are eligible per the National Immunisation Schedule or state programs. So catch-up vaccination aims to provide that optimal protection against disease as quickly as possible by completing a person's recommended vaccination schedule in the shortest but most effective time frame. And this can be conducted through regular routine immunisation service delivery, and whether that is fixed in your general practice or whether they're outreach programs, school programs, mobile clinics, whatever. You may even have periodic strategies where you might have a bit of a campaign for the month of October that you're going to chase down every single person that is missing a particular vaccine, perhaps. And just making sure that every person that is on that overdue list has the opportunity to come in and get that vaccine that they're overdue for. But there are lots of rules and regulations around catch-up. So I'm really hoping that tonight I can give you just a little bit of guidance around them. We'll see how we go anyway. But this is a poll that we had before, but it's, what is the age criteria? Have you got this one, Monica, for an Aboriginal Torres Strait Islander child living in South Australia to receive a missed dose of hepatitis A vaccine?
Is the right one?
Yes, I think we can work with that one for sure. So we'll just give you a few minutes just to see. Okay, a couple more still coming in. All right, that looks like it's about it. Okay, well, I'm going to surprise you all because the question that we're asking is if they have missed a hepatitis A vaccine. And the answer is actually C. So hepatitis A vaccine is funded under the NIP for Aboriginal and Torres Strait Islander children living in Queensland, Northern Territory, Western Australia and South Australia. But each state and territory sets the rules on catch-up vaccines for children aged 5 years and older. And according to SA Health, the upper age limit for an Indigenous child in South Australia to receive any missed hepatitis A doses is 10 years of age. So if they are Aboriginal and they are now older than 10 years of age, then they are not eligible to receive the 2 doses of hepatitis A vaccine. Okay, up to their 10th birthday. So there's lots and lots of principles to catch-ups. We must consider the age of the child that's presenting for vaccination. Some vaccines are age limiting. For example, there's no catch-up for pneumococcal vaccines after 5 years of age for healthy children. In almost all cases, we do not start a schedule again if there has been documented evidence of a schedule already started, regardless of the interval since the last dose. We always count the doses that have been given as part of the schedule. One exception to that rule is oral cholera vaccine. So we won't go there because it's not an NIP vaccine. We definitely want to give all vaccines that are due at that visit. We don't wish to defer them. Remember that window of opportunity for disease is open until the child receives the recommended vaccines. Be careful not to choose which vaccines you will or will not give the patient if the patient refuses to have multiple vaccines at that visit. We need to be quite careful about this, because if we were to say, look, I think today we should give XYZ vaccine and we can wait and give ABC vaccine later, what happens if, for example, that person then contracts one of those diseases of A, B, or C, and under your advice, they deferred the vaccine, they delayed it, then they forgot about it, and now they've got the very disease they should have been vaccinated against. So there really does need to be a very big discussion around catch-up vaccines, and because every vaccine they're overdue for is very important. So in saying that, of course, we need to be responsible, and particularly we need to give that professional guidance. So we'd have a little look about what vaccines may they already have had and which ones have they not had. So let's say we're tossing up between a DTPA vaccine or an MMR vaccine. Well, at the moment, there's lots of pertussis around, and perhaps they need the pertussis protection. But measles is so contagious, although the risk of disease is really low within Australia. So this is where this conversation is going to be. Have they had previous DTPA doses? Maybe they have, but they've had no MMR doses. So maybe that's the conversation that you would need to be having. But providers just need to be really confident and reassuring to patients that children can receive multiple vaccines quite safely. Having multiple vaccines at the same visit really does not increase the likelihood of adverse events to any significant level. If they're going to get a fever, they would get a fever with 1, 2, 3, 4, or 5. It wouldn't really matter. But let them know what is due, what is recommended, that there's no safety concerns, that the vaccines really contain only a small amount of antigens compared with the large amount of antigens that children encounter from other sources every single day. We really can't overload the immune system with vaccines. So get them to think about, you know, when that child took its very, very first breath of life, how many antigens it would have been exposed to. With their little toddler sitting outside on the grass, in the sandpit, eating dirt, whatever, how many antigens is that child being exposed to at that time? It's many, many more than what is in vaccines. Right, we've got a third poll. So hopefully you're still alive and awake, and let's go through this one. So Sammy is 6 years old. He arrived in Australia 3 months ago as a refugee. He has no written vaccination records, and his parents cannot remember what vaccines he has received. They may believe that he did receive some, but they can't remember what they are. So would you plan to include HIB in the catch-up vaccination schedule that you are planning for him? let's see how you go. Give you a little while longer. There's a few people thinking. Maybe there's a few people that are quickly checking up that catch-up schedule for Hib vaccines, maybe. You're almost there. Okay, I think we're pretty much there. All right. So the answer is actually C. We would not be giving Sammy a Hib vaccine. And this is one of those cases that I mentioned before about considering the age of the child when you plan a catch-up. If you have actually downloaded a copy of that catch-up schedule for Haemophilus influenzae type B or Hib vaccination for children less than 5 years of age, you can see clearly that Hib catch-up is only for children less than 5 years of age. And this is because the majority of invasive Hib disease was found in children less than 5 years of age. The incidence of Hib disease over 5 years of age is so much less. So the catch-up does not extend. Sometimes, though, if you are giving a big catch-up to a child like this, you may choose to use perhaps an Infanrix Hexa or a Vaxelis, so a 6-in-1 antigen vaccine, and therefore that does contain the Hib component. So we're not going to harm Sammy by giving him a 6-in-1 vaccine that contains Hib. But it's just not a dose that is recommended for him being at 6 years of age, that's all. So that was our correct answer. So we know that those inactivated vaccines can be administered at any time before or after as other vaccines, or even on the same day, of course. But certainly if we're giving live parenteral vaccines, so they're your intramuscular live virus vaccines, then of course we can give them on the same day, or we must separate them by 4 weeks apart. So if you are planning catch-up schedules and they are due to receive 2 live virus vaccines, then you may as well just give them on the same day in opposite limbs. Because that would be a case of perhaps someone that's 15 years of age where we can't use MMRV, then we would need to be giving them measles, mumps, rubella, as well as a varicella. So on those occasions, you would prioritise and give those 2 vaccines at that same encounter to make sure that they're protected from those diseases as quickly as you possibly can. So obviously, we once again need to consider age. So remember your Rotarix vaccine, that first dose is only recommended between 6 and 14 weeks, or certainly before the child turns 15 weeks of age. But if an infant has inadvertently received that first dose of rotavirus vaccine after that particular age, then they can continue the course. They can receive that remaining dose as per the schedule, so a second dose, if they did not, thankfully, get intussusception after that first dose. But you just need to separate those doses of 4 weeks between the doses. and just making sure that that second dose is given before the child turns 25 weeks of age. Definitely count antigens, not vaccine names. So when you're planning your catch-ups, count how many doses the child has had of each antigen. So how many diphtheria, tetanus, pertussis vaccines, how many measles, mumps, rubella vaccines, how many Haemophilus influenzae vaccines, etc. And so remember that many vaccines that have been given overseas have different vaccine brand names. For example, Hexacil is a vaccine that's used in India. It's very similar to our Infanrix Hexa or our Vaxelis. However, it does contain a whole cell pertussis component rather than an acellular pertussis component that we have in our vaccines. Daptocel is used in the United States, and that would be equivalent just to our DTPA vaccine. Omzita is a measles, mumps, rubella vaccine, combination vaccine that's given in South Africa. So you'll see lots of different names that are given, different brand names. The AIR requires particular information to form a vaccination status assessment of an individual. It does not need to be a complete record of every single vaccine that the individual has received. So if some vaccine doses that the person has had do not align with the Australian schedule or approvals, then just don't add them to the AIR. For example, this particular example that I've got here, where there was a dose of polio vaccine given at birth, it doesn't align to our schedule. It's not going to be accepted on our schedule, so we wouldn't bother putting it onto the AIR. If you've got a child that has a monovalent measles vaccine, so not a combination MMR, but just a plain measles vaccine at 9 months of age, which a lot of countries give to their little babies, it's an irrelevant dose here. The child still needs to have 2 doses of MMR vaccine after 12 months of age. So it's pointless putting it on the AIR. It's irrelevant. So just try and align the vaccines that the child has received with the vaccines that are relevant to us. If a child has received 4 doses of polio vaccine before 18 months of age, but only 3 doses of DTPA vaccine, you don't need to add every single polio dose that they've had. Just align them with what the child needs here in Australia. So laboratory testing might not be sensitive enough to pick up vaccine-acquired antibodies. So just always keep that in mind. If there is a documented history of receiving 2 doses of measles, mumps, rubella vaccine after 12 months of age, serology is not needed. Please don't feel that you need to assess them for a vaccine response. If the child has previously received a varicella vaccine, serology is not needed. If the child has previously received a course of hepatitis B vaccine, as per the schedule in another country, but does not have documentation, you could administer 1 dose of vaccine and check serology 4 weeks later. If the anti-HB level is greater than or equal to 10 million international units per mil, the person would be considered immune. This is often not really preferred for infants and young children, obviously, due to the trauma of drawing blood. So alternatively, just vaccinate them as per the schedule, as we cannot over-vaccinate an individual with our routine vaccines. There's a suite of resources that are available to you. Definitely look at the Australian Immunisation Register. You've got that due overdue report, which is that 10A report, which is a due overdue report by immunisation practice. And that provides accredited medical practices registered for PIP, or the Practice Incentive Program, with individual AIR individual records, immunisation records that are due or overdue. So for practices without a PIP ID, they can use another report, which is called a 21A due overdue report for the same type of information. There is a 20-minute online module that explains how to request, modify, view, customize, and interpret the 10A report. So you can have a little look for that on the Australian Immunisation Register website. Obviously, you're going to use any hard copy immunisation records that the patient may have. There may be a departure check or some immigration records as well. Obviously, you can contact a previous vaccination provider, and sometimes we just need the patient, to assist the patient, I suppose, really to be a bit of a super sleuth, a little bit of a detective. Contact previous providers and ask them to check their records for a vaccination history. Remember that the AIR is an incomplete database. It was expanded in 2016 to include adult vaccines administered on or after the 1st of October 2016. So any vaccines administered to anyone that was 7 years of age and older, they may not be recorded on the AIR. Vaccination histories on general practice software did not transfer to the expanded AIR, but some of the council software programs, the histories did transfer. Just remember too the calendar converters. So there are calendar converters for countries that use a different calendar system to us. So the Hijri calendar, or Arabic calendar, also known in English as the Muslim calendar and the Islamic calendar. A given Hijri year will usually fall in 2 successive Gregorian years, or a Gregorian or a Western year. What we have will always overlap 2 or even occasionally 3 successive Hijri years. The Nepali calendar is also known as the Bikram Sambat Nepali calendar. The current Nepali year in Nepali is actually 2081. Very different to where we are. The Nepali calendar is approximately 56 years and 8 months ahead of the English calendar, known, of course, as the Gregorian calendar. So definitely, if you see some overseas records with really unusual dates on them, then you may need to look at these calendar converters, and you can just Google them. Obviously, there's some translation apps that you could be using. There's also some resources here that may help you with translating foreign immunisation records. There's some foreign language terms, also foreign product table in the immunisation handbook as well. But certainly just take your time, or buy some time. Don't rush. perhaps ask the parent or the patient to send in their records to you a few days before their appointment, so it gives you a little bit of time just to sit down and try and work out what you're going to be giving at this first visit. But if you don't have that time and they've just arrived and they have no vaccine records with them, just give them something. Just give them something. If you can't, if you can identify just at least one vaccine that is overdue, then give it. It could be that, gosh, they've never had a measles, mumps, rubella vaccine. Just give that one. And then just let them know that it's going to take you a little bit of time to work out an appropriate catch-up schedule, and that you'll be in contact with them again and be booking the next appointment for them. It's really recommended that providers recalculate the catch-up at each encounter, unless, of course, they have come back in exactly on the date that you advised them when you gave them a copy of the previous catch-up. Sometimes we may continue a schedule someone else has planned, but the patient did not come in on, let's say they were due on the 15th of May. They actually came in on the 4th of August instead. And this might actually mean that they are now over the age limit to receive a certain vaccine that might have been on their schedule to be given in May when they were supposed to come in. So always recalculate. Don't just do one schedule and then think that you can just use that schedule continually. So, looking quickly, clearly this is a child that was vaccinated overseas, but thankfully there is information that is written there in English as well. So if we were to look quickly at this overseas history, this person was born on the 20th of December 2017. They're now 6 years and 7 months of age. So what vaccine or vaccines could you identify immediately that you could just go right ahead and give it today? So if you wanted to pop something, an answer in your Q&A box or something like that, absolutely you can go ahead. But for the sake of time, let's just choose something. So we know he's 6 years and 7 months, and we can see by that history that he has never had a measles, mumps, or rubella vaccine, and he certainly hasn't had a varicella vaccine. So they would be at least something that you could give today. So would we give a Prevnar 13 to this child? It was due for him at 12 months of age. But we wouldn't give it, because if we were to look at the pneumococcal catch-up tables, the child is over the age for a pneumococcal catch-up vaccine. Could we give a funded Bexsero vaccine? That would be something to consider as well. The child's now residing in South Australia. And yes, we certainly could, because meningococcal B can be given to all children born on or after the 1st of October 2017. And then you would, and this child was, so then you would put in a recall for that second dose in 8 weeks' time. And what about that single dose of meningococcal ACWY? We could certainly go ahead and give him one of those as well, because he's under 10 years of age. So we could certainly catch that up. What about another DTP IPV? He certainly missed his 4-year-old dose. And if we were to give that to him now, would he need to be recalled for dose 5 of DTP? he would not be needing dose 5 because he would be receiving dose 4 after he was 3.5 years of age. So the next DTP vaccine that this child will receive will actually be in year 7 in high school. So you can really see the intricacies. And so please take the time to plan. But just at a glance, if you can see something to give this child today, then we would give it. I'll just have a look at the questions box because I did see something here. Stephen, to be honest, there are lots of anti-vax on social media and they misuse information to agenda. I've noticed aggressive webinar attendees only in webinars about vaccines or vaccine preventable diseases. So we certainly know that there's a lot of misinformation around, and so it's really important that as a health professional, we understand that and always, ask somebody where did they hear that information, because we need to show an interest in what information is actually out there. So Sandra, hello Sandra, a lot of older children, we're needing up-to-date vaccination for a placement at university or for a job, have been asking to have another varicella vaccine, as the place of employment are not accepting 1 dose of varicella vaccine as being up to date. Any suggestions, read this? Look, we certainly do follow the guidelines in the immunisation handbook. And we certainly know that if a child received a varicella vaccine prior to 14 years of age, it is only the 1 dose that is funded. However, a 2nd dose is recommended but not funded. So the universities may be being a little proactive. I'm not 100% sure on why they are not accepting, but certainly this individual, being a person over 18 years, over 14 years of age, would need to pay for that varicella vaccine as well. Like I said, we cannot over-vaccinate anybody anyway. Okay. So you're going to, I'm more than happy for you to have access, obviously, to this slide deck. I hope that's okay, Monica. And I do know that this webinar is being recorded, so you can always come back and have another look at this. But these are some tips that were put together by the immunisation nurse practitioners that work at the Benchmark Group, which is a training organisation in Melbourne, and they've kindly shared this with me. But it's just a nice little 1-pager where you've just got all of those really quick, handy hints, really. So, of course, when you are planning catch-ups, just run them past one of your colleagues, because 4 eyes are better than 2. Alternatively, phone a friend. You're definitely able to contact the SA Health Immunisation section on 1300 232 272 and just ask for some assistance with a catch-up. But hopefully, when we go through the catch-ups in this presentation, it might just give you a little bit more confidence to try and work through those catch-ups yourself, and then phone the immunisation section and just get them to double check that you got it all right. Because, and I know that you're super busy, but the more that you do, the quicker you are going to be at doing them. So this is what you could be faced with in your practice or organisation, and these are all records that have come from overseas. And usually this is the reaction when providers are faced with an overseas history. The process of deciphering the history, adding the history onto the AIR, and planning a vaccine catch-up can be absolutely daunting, and not to mention time consuming. So you do need to somehow quarantine some time to work out these complex catch-ups. But regarding the time you need to spend on planning a catch-up and adding histories onto the AIR, once again, I don't have the magic wand and I can't help you. However, hopefully some of the pointers that I'll give you can steer you in the right direction. New arrivals with certain permanent residence visas and selected temporary visas can use a free translating service through the Department of Home Affairs. If they want to get documents translated that are in the name of a family member, for example, their children's vaccination records, then what they just need to do is create a separate application for each of their children, because each application will allow up to 10 documents to be translated for free. If they're not eligible for this particular service, then there are a number of commercial translating providers that they can access. The National Accreditation Authority for Translators and Interpreters, which is NAATI, N-A-A-T-I, is really the national standards and accreditation body for translators and interpreters in Australia. So whoever they go to should be able to translate their immunisation records. But it is up to the parent to get those records translated. They will need them if their child is in childcare or going to school, because if they're going on camps or excursions, then usually there's a box on the excursion consent form to say that they're up to date with their tetanus vaccines, etc. Or if they present to an emergency department with an injury, certainly the medical staff will need to know, do they need a tetanus booster or not? But for the providers, you people out there, if somebody does come in with records that are from overseas, if they have been translated, please, please add them to the AIR. We try and have a complete record if we can of the vaccines that this person has had, because this person may go to other providers. And so the AIR is that centre point for all these records to be stored. So if we're looking at a real simple catch-up, so let's look at David, who's 9 months of age. His parents identify him as Aboriginal or Torres Strait Islander. Whoops, I've got an extra word in there. He presents with an eczema-like rash on his leg, but is otherwise well. You note that when you do check his AIR history, there is no record of him receiving his 6-month-old vaccines. You chat to the parents who consent to vaccination today. So we'll have a little look at this one without us getting too bogged down to anything too complex. So this is what his AIR record looks like. It's a nice record. He's had his birth dose of hepatitis B. He's had his other vaccines absolutely on time, which is fantastic. So the first thing we want to look at is, what resources are you going to use? And these resources are from the immunisation handbook. You could look at the catch-up worksheet for the children less than 10 years of age, and you can also be looking at the other sheet that tells you how many doses of vaccine the child should have received by their current age, and these are for the funded NIP vaccines. So if we use that catch-up sheet, we'd obviously have the child's name, we'd have that date of the assessment, the child's date of birth, and their age at presentation. And from that AIR history, we would then fill in the details of what was the last dose number and the date that it was given. So we would go through and we would fill all of that out. Now we look at the number of doses needed at the current age of the child. So we look at that catch-up sheet, the number of vaccine doses the child should have received by their current age. And we can see that this child should have had 3 doses of DTPA, polio, hepatitis B, and Hib. However, since David is an Aboriginal child living in South Australia, he is also due a 3rd dose of Prevnar 13. So we would just write a 3 in those columns. It's always a good idea just to write, Indigenous infant in that comments column, just because if another staff member was to pick up this worksheet, then they would be able to see why this child was given that dose 3 of Prevnar 13 when it's only 9 months of age. And similarly, if this child had medical risk factors and was also recommended to have that dose of Prevnar at 6 months of age, you could write in that comments column that medically at-risk child. So then we would go to that next column and have a little look at what we would be needing to see today. And we could be giving an Infanrix hexa or a Bexsero dose, absolutely. We'd also be giving some Prevnar 13. We'd also be giving a Bexsero that the child has already received. If they haven't received both doses already. So if we're just going to give these today, then what else would you be offering today? We'd certainly be talking to the parents about a flu vaccine for sure. So that form that we've been using, that catch-up worksheet, doesn't include our Bexsero. So make a note on there if he has received Bexsero doses already. It doesn't also have flu vaccine on there. So just make sure that you are writing those additional doses in. So you would definitely be offering him a flu vaccine and adding it onto the form. The other thing that we would be also doing is putting a recall on for David to come back in 1 month's time or in 4 weeks' time for his 2nd flu vaccine. We'd also then put a recall for him to come in for his 12-month-old vaccines, which would be due on or after the 1st of November 2024 when he turns 12 months of age. He would be recognised as overdue at 13 months of age if he does not receive his 12-month immunisations on time. So just try and keep this little one on schedule. Okay, let's look at a slightly more difficult catch-up. So Betty's 12 months of age. She's non-Indigenous. She's recently come into foster care and is unvaccinated. How do we start this catch-up? So, little Betty, unvaccinated, so we're absolutely starting from scratch. So, this time, I'm going to use a worksheet that I developed because it therefore include the additional vaccines used in the South Australia immunisation program. So we'd start by adding in the fact that she's had no vaccines previously. We would then go to our table that's titled number of vaccine doses the child should have received by their current age for the NIP vaccines. And we can add in that by 12 months of age, which is her current age, that she should have received this many vaccines. We know with our state-funded MenB program, she should have also received a dose of Bexsero at 6 weeks of age and at 4 months of age, and again when she did turn 12 months of age. So we also need to calculate how many doses that she is now due. So given that Betty is totally unvaccinated, we know that we are going to be giving dose 1 of everything except rotavirus vaccine because she is over the recommended age to commence the course. So poor Betty. Today she's going to be due either an Infanrix Hexa or a Vexelis, a Prevnar 13, a meningococcal B, meningococcal ACWY, an MMR, and a flu vaccine because we're in the middle of flu season and there's a lot of circulating disease. So that's 6 needles today. What are your thoughts on 6 needles? Are you comfortable with 6 needles? Can we give them all today? Is it going to be a problem if we do? Are there any perhaps that we can delay by 3 days? We would always prioritise the NIP vaccines over others because the NIP vaccines are assessed for Centrelink payments. So in this case, we could, if the parent did not consent or the foster parent did not consent for all 6 vaccines to be given today, after consultation and giving all the information that you can, we could delay the MenB because it's a state-funded program, not NIP, and MenB is still a rare disease. We could delay an influenza vaccine by 3 days because that's also not going to interfere with Centrelink payments, even though it's a funded vaccine for little Betty. It's not going to influence Centrelink payments. We also have to understand whether Betty is going to be a bit of a flight risk. Do we really trust that her foster parent is going to return in 3 days' time to have those vaccines that we've decided to delay by 3 days? Is it convenient for the foster parent to return? Maybe the foster parent is working as well, maybe. They don't have transport. Maybe it's not possible. Or is it more convenient to the foster parent that the child actually does have all the vaccines at one visit? So we would have to start then looking at some of those other catch-up tables. And these are all the different catch-up tables that you'll find in the immunisation handbook. And we'd need to work through all of these documents. Just remember that there are 2 catch-up documents for pneumococcal conjugate vaccines. So these are your Prevnar 13, your Prevnar 20, your Vaxneuvance, which is the pneumococcal conjugate vaccine with 15, which is a 15-valent vaccine. So these are those conjugate vaccines. So we just need to, I really suggest that for these 2 documents that look almost identical, is that you highlight which one you're going to be using for your Aboriginal and Torres Strait Islander children that are in Northern Territory, Queensland, South Australia or Western Australia only, and children from all states and territories with risk conditions. So they belong on one. The other one is going to be for Aboriginal and Torres Strait Islander children living in New South Wales, Victoria, Tasmania or ACT, and children from all states and territories who do not have risk conditions. So these are your healthy children that are less than 5 years of age. So in other words, if Betty was an Aboriginal baby, for example, or if she was medically at risk, we would be looking at that other catch-up table. However, Betty's healthy, she's non-Aboriginal, she's just unvaccinated. So we're going to be using this particular pneumococcal conjugate vaccine catch-up table. So if we were using all of these documents, we would then write in the minimum interval for when the next dose is going to be due. All right, so we're going to look at that further doses and that interval column. So we know that that Infinrix Hexa, or it might be a Vaxelis that you have in your fridge, that dose 2 is due 1 month after dose 1. She's not eligible for hepatitis A. She's over the age for rotavirus. No further doses if you look at the pneumococcal catch-up table, you'll see that no further doses of pneumococcal vaccine are recommended. Bexsero dose 2 is due 8 weeks after dose 1. She only has the 1 dose of meningococcal ACWY vaccine. She will have her second dose of MMR along with varicella as an MMRV when she gets to 18 months of age. So we don't need to give anything for a little while. Her second flu vaccine is due 4 weeks after dose 1. You will also note in the catch-up tables, some vaccines are due 4 weeks after and some are due 1 month. There is a difference between 4 weeks and 1 month. Always bring the patient back at the later of the 2 dates. So if we were vaccinating on the 9th of August, 4 weeks would bring us to the 6th of September. But if we were going to 1 month later, it actually takes us to the 9th of September. So there is that little bit of difference. So just make sure that you're calculating your minimum intervals very, very carefully. So for Betty, the next month that we see her, in 1 month's time, she's just going to receive 2 needles, and that's her Infinrix Hexa dose 2 or her Vaxelis dose 2 and her influenza dose 2. So if we were to run this particular scenario through the immunisation calculator, this is the schedule that would be recommended. And as you can see, the calculator will list the NIP vaccines and vaccines that are not on the NIP that are recommended are listed with a $sign next to them. And it does not include influenza vaccine, but I suspect is due to seasonality. However, right at the end of this document, if we were to look at the true document, it does remind providers about influenza vaccine for children. So the calculator will also give you a plan for future appointments as well, which I've not included on this slide. But just remember, it's going to put a date for those next appointments. And like I said, if the child does not come back on that date, then we really do need to be recalculating it. And I'll give you an example on our last scenario at the end of the presentation. This is our last poll. So this is Lucy, who's 3 years of age, and she's unvaccinated. You wish to administer some vaccines today, which is great, to commence her catch-up. Are considering MMR and varicella? So would you plan to administer MMR or MMRV? A is that you would put MMR first because MMRV should always be given as the second dose of MMR in children less than 4 years of age. Or you'd give MMR first so you can see if she has a reaction. Or you'd give MMRV first because it will protect her from 4 diseases instead of 3. Or you would give MMRV first and then she would not need to have another MMR dose. So let's have a little think about that one. Okay. We've got a little bit of a smattering all over the place, really. We've got 53% of you saying A, 7% B, 33% C, and 7% D, or up to 13% is D. Okay, so the actual answer is tick, MMR first, because MMRV should always be given as the second dose of MMR in children less than 4 years of age. And this is because of a small but increased risk of fever and febrile seizures when MMRV is given as the first dose of MMR-containing vaccine in this age group. So just remember to, oops, that one. Just remember to always look at the handbook if you're not really that sure about what vaccines that you should have, or certainly look up all of these catch-up tables, have them in a folder somewhere that they're quite easy for you to access. So just moving along, Charlie is an Aboriginal and Torres Strait Islander and is 4 years of age. He's born on the 1st of June 2020 at 30 weeks gestation and weighed 1.1 kilos. He required home oxygen until he was 18 months of age and has been diagnosed with chronic lung disease due to prematurity. He has recently moved to South Australia, and due to vaccine hesitancy, his mother has been spacing out his vaccines. But since her nephew was recently diagnosed with whooping cough, she now wants Charlie caught up to date. And so you check his air record, and this is what she found. So he's had an Infanrix Hexa when he was 3 months and 21 days of age, as well as a Prevnar 13. And then he had his second doses when he was 9 months of age. And then on the 15th of the 8th, he had some Pryrix. And given the fact that he was born on the 1st of the 6th of 2020, that would make him 14 months of age. He just had a dose of Pryrix. So, of course, he didn't have any rotavirus vaccine because he was over 16 weeks of age when he had those first vaccines given. He was not living in South Australia at that time, so he was not offered meningococcal B vaccine. So once again, we just start with what we know. And this is what we know. So note that I have also written a note to remind myself and other staff that Charlie was born preterm and is a medically at-risk infant because he has been diagnosed with that chronic lung disease due to his prematurity. So we now write in how many doses of vaccine should he have received by his current age. So using our catch-up tables, we know Charlie only needs 4 doses of DTPA, but Since dose 4 will be given after 3.5 years of age, he will not be needing the 5th dose. He should have had 3 doses of polio. Because he is having dose 3 after 4 years of age, he's not going to be needing dose 4. And he should have had 3 doses of Hib, and based on the Hib catch-up schedule, and also 3 doses of hepatitis B. Because he is an Aboriginal child, he's eligible for 2 doses of his hepatitis A. And because he has a medical risk condition, he should have received an extra Prevnar 13 dose as well. Because of his medically at-risk condition, he's also recommended to have a dose of Pneumovax 23 now at 4 years of age. Since he lives in South Australia, he's now eligible for 2 doses of meningococcal B, and he is overdue his NIP-funded meningococcal ACWY vaccine. He has had a valid dose of MMR previously, but he is overdue MMRV. And of course, we would be wanting him to have a flu vaccine as well. So, what do we think he needs now? So, today we would say that he actually needs his 3rd dose of DTP, polio, Hib, and Hep B. So that's a Hexa or a Vaxelis, dose 1 of hepatitis A, dose 3 of Prevnar 13, dose 1 of meningococcal B, dose 1 of meningococcal ACWY, dose 2 of MMRV, and a flu vaccine. So that's 7 vaccines today. Once again, would you give them all to him today? Particularly when you are considering the previous vaccine hesitancy that the mother has had. And if you weren't going to give them all on the same day, which ones might you choose, perhaps to discuss with the parent about deferring? Well, once again, hepatitis A and the meningococcal B are not going to be assessed for Centrelink purposes. But what about flu? Given the amount of influenza that's circulating, maybe you wouldn't defer the flu vaccine since he has got a diagnosed chronic lung disease, and flu could be a very serious disease for him. So, now what? When are we going to bring him back for all of the other vaccines? Well, now it starts getting pretty messy. So dose 4 DTP is due 6 months after dose 3. So it's a 6-month minimum interval. He doesn't require any further doses of polio, Hib, or hepatitis B. He needs a 2nd dose of hepatitis A vaccine 6 months after dose 1. He needs dose 4 of Prevnar 13, and that's due 2 months after dose 3. He needs a dose of Pneumovax 23, but we need to just wait because we're giving a conjugate pneumococcal vaccine to him. We just need to make sure that we observe the minimum intervals. So the minimum interval really can be 2 months, recommended between a Prevnar 13 or a conjugate pneumococcal vaccine and Pneumovax 23, which is a polysaccharide pneumococcal vaccine, is 12 months. However, 2 months is an acceptable interval. So that would be a case-by-case basis. And for someone like Charlie with a chronic lung condition, you may shorten the interval to 2 months. But just pop on a recall because he would be needing to have dose 2 of Pneumovax 23 in 5 years' time. A second dose of meningococcal B is due 8 weeks after the first dose. He's now up to date with his MMR and his MMRV. But since this was the first time he's been receiving flu vaccine, and he is less than 9 years of age, he is due a second flu vaccine 4 weeks after the first. So, an interesting little catch-up that you may or may not want to try and conquer. But if we were to put Charlie through the catch-up calculator, this is actually what we would find. We've got all of his details. He's got a chronic respiratory disease. He was a preterm infant. He weighed less than 1,500 grams at birth. He's now 4 years, 2 months and 9 days of age. We've popped in his vaccine history, and we've also popped in what we gave today, as well as that flu vaccine that we also gave. So what would the future plan look like according to the catch-up calculator? Mindful that flu will not be displayed here, and the meningococcal B vaccine, the catch-up states is due on the 7th of September, which is actually only 1 month after dose 1. The product information for Bexsero states that children aged 2 to 10 years at the start of their vaccine course should receive 2 primary doses, with an interval not less than 1 month between the doses. However, ATAGI, the Australian Technical Advisory Group on Immunisation, recommends that children aged 2 to 10 years at the start of the vaccine course should receive 2 primary doses, with an interval of not less than 8 weeks between doses. So in this case, you would need to choose whether you are following the product information that comes with the vaccine, or whether you are choosing the ATAGI advice. I would be choosing the ATAGI advice. I'd therefore defer the dose until you have observed an 8-week interval. And of course, the vaccine is funded here in South Australia. However, you would bring Charlie back on the 7th of September for his second dose of flu vaccine. So if we look across to the right, on this particular calculation, it is stating Charlie will need a 5th dose of DTPA. However, after you have given Charlie his dose 4 DTPA, that will actually drop off. And this is why I'm saying it's so important to recalculate catch-ups at every encounter that you have with the child. All right. So what I did after downloading this one is I actually made Charlie a year older, and therefore did an assessment with having given him that 4th dose of DTP, and it certainly had dropped off the catch-up that was planned for him. So just be very, very aware of redoing these catch-ups. Can't stress that enough. So it also will state that the additional doses of meningococcal B is required at 15 years of age. So 1 here and 1 here. Now, SA Health and myself have asked this question to the handbook writers to clarify why this child is now looking at having 4 doses of meningococcal B, because that is not mentioned anywhere in the handbook, that they need 4 doses. The response from the handbook writers was, and I quote, "While the handbook does not specifically provide the recommendation for revaccination of healthy adolescents who were previously vaccinated in childhood, the advice from experts from NCIRS, National Centre for Immunisation Research and Surveillance, is that revaccination in adolescents is recommended due to the known risk and epidemiology of cases for the age group. And at this time, 2 doses of MenB vaccine should be given." The experts note that the handbook is currently somewhat unclear on this issue, and that further clarification around revaccination in adolescents is being discussed for a future update of the meningococcal disease chapter of the handbook, and that the number of doses for this situation is under review. So, at this stage, if a child less than 15 years of age has received 2 doses of MenB vaccine, either under the SA Health program or if the vaccine was privately purchased, and the parent wishes now to have the child receive these additional doses because they're over 15 years of age, they can be given, but they would not be funded vaccines. The parents would need to purchase them on prescription. So, phew, I don't know whether that has made any sense or if in fact it's just as clear as mud. But all I can say is use the resources available to you, or develop your own catch-up worksheet that just works best for you. I could certainly improve on the one that I've created, much bigger boxes for a start, because you've got to write so much information into them. You could also plan future doses and put in that 6-month interval for your hepatitis A vaccines, etc., so they don't get missed. But realistically, I think keep it to the next visit, because then it forces people to recalculate that catch-up. Definitely call for help if you're unsure. Get somebody to check it for you. Definitely keep attending immunisation education sessions whenever you can, and really keep your knowledge up to date, because so much changes in this program. It is not an easy program. It is becoming more and more complex. We are getting more and more vaccines. The number of vaccines that are in the vaccine pipeline is mind-blowing. So we have more to come. The first thing that we're probably likely to be looking at potentially are RSV vaccines. Our general practice is also going to be getting monoclonal antibodies, RSV monoclonal antibodies, to be giving to babies. We don't know for sure, but your vaccine program is going to continue to grow, and we must keep our immunisation providers educated, absolutely. We need to try and understand the main reasons that parents are concerned or hesitant about vaccinating their children. We really need to build trust, and we do that by being honest, and by being transparent. We can't just brush concerns aside. We can't just say, oh, look, it's just a flu vaccine. We give them all the time. Nothing will go wrong, because you can guarantee Murphy's Law something might go wrong with that child. So we need to discuss all of those risks and benefits, and we just need to keep the door open. They may say no, but the next time you see them, so Mary, have you thought any more about the vaccines for your children? No, I don't want them, etc., etc. And she might refuse vaccinating them for 6 times. But maybe on that 7th time when you said, Mary, I'm going to ask you again, I'm really sorry for bugging you. Have you thought any more about it? Actually, yes, I have. And neighbour's child's just been in hospital with something, or my nephew, or whatever the case may be. And it might be that personal experience that actually changes their mind. So just keep that door open, keep that relationship going. But we do absolutely know that educating and really taking time with these parents really does show that modest improvement in terms of the parents' attitude around immunisation, and it certainly does raise immunisation rates. Remember, the AIR help desk is there. If you've got a question around something to do with a history that you've uploaded and you've maybe made a mistake or something along that line that you need corrected, please contact the AIR and they will give you some help. I know that sometimes you're on wait for a very, very long time, and but hopefully they can improve that service a little bit. But just remember, the more catch-ups that you do, the quicker that you will be able to do them. When I first started in the immunisation program 24 years ago, I remember being, sort of just shadowing an absolute expert in this program, and it was one of the local immunisation coordinators at one of the divisions of general practice. And she would go out to these practices and I would just tag along as an absolute newbie. And I would be watching her work out these catch-ups. And for the life of me, I couldn't get it. I just couldn't get it. I just couldn't get it. And then I really had to get her to break it down in a really simple explanation. And then I got it. I still, to this day, write the catch-ups down. I can do the simple ones in my head, absolutely. But the catch-up rules have changed over the years as well. So make sure that you're using the latest rules out of the handbook. So, but definitely use all of those resources that are there. They'll help you get on the right path. And, like I said, practice makes perfect. So I'm just going to have a little check here of the question box and see if there's anything here. Yeah, absolutely. Do we calculate vaccine dosage after corrected age calculation? Okay, we don't correct age for children. So if they were born prematurely, we vaccinate them according to their age since birth. So if the baby was born at 32 weeks, they are still eligible to come in for their 6-week-old immunisations because they are 6 weeks old. We do not do any age correction at all. And the simple way that I often will say to providers, ask the parent, when will they celebrate the baby's first birthday? Are they going to celebrate its 12-month birthday from the date that it was born, or from the date it should have been born? It's going to be from the date the child was born. So it's from the date the child was born that we give the vaccines. So I hope that with all of this, I just would really like to thank you for listening, and I hope that you found the webinar helpful in some way and that I haven't confused the absolute daylights out of you. But if you do need to go back and rewatch this webinar, then please do so. But certainly if you need some support, then definitely the immunisation section will be most helpful to you, no doubt. So I will stop sharing if you like, Monica.
There's a question on dosage calculation.
Yep, that's the one that I just
Okay.
answered
Sorry.
there, just in
I was
regards
distracted.
to, yeah, just in, we just don't calculate dosage after a corrected age, because we don't do corrected age. So, but we do have, you know, date of birth rules. Okay, so if a child, you know, from their date of birth is now, you know, over a certain age, there are some vaccines that we don't catch up, and they are those things like Previnars and Hib vaccines after the age of 5 years. So, and the number of doses that we would give will also change because of their age from the time they were born. I hope that makes sense.
Yes, thank you so much, Angela. Thank you for presenting. And good night, everyone. Don't forget to complete the evaluation for this session. Thank you.
Thank you very much, everybody. Enjoy your evening.